Good afternoon, everyone. My name is Veronica Vital. I am a clinical assistant professor for the College of Nursing at the University of Arizona and will serve as moderator for this session. I wanted to provide you with a few housekeeping items before we get started. If you hold CHES or MCHES status and did not submit your ID number during registration, please submit your name and ID number to virtualsim_CEUS@minorityhealth.hhs.gov to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute. Please post your questions through the Q&A corner icon at the top of the screen for responses from the speakers. Due to limited time, not all questions will be addressed during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following this presentation. It is my pleasure to introduce Dr. Matias Valenzuela. Dr. Matias Valenzuela is the Equity Director for Public Health, Seattle and King County. For the COVID-19 response, Dr. Valenzuela serves as the Director for Community Mitigation and Recovery. Previously, he founded and directed the Office of Equity and Social Justice in King County, spearheading a county-wide effort to address the root causes of inequities, especially racism, working with all county agencies and the community. Dr. Valenzuela has worked at King County since late 2000, including as a lead for equity and social justice since its inception in early 2008. With more than 25 years of public health experience, Ms. Lacey Bibbs serves as the Director of Office of Health Equity, whose purpose is to increase awareness of health disparities, enhance patient-provider communication, improve cultural and linguistic competency in delivering health services, and improve coordination and utilization of research and outcome evaluations, and strengthen leadership to address health inequities. Ms. Lacey Bibbs has presented the work of OHE at numerous state, local, and national conferences, and is currently working across cabinets within state government to address health disparities and inequities as relates to where we live, learn, work, play, and pray. The objective of this session, using data to inform equitable COVID-19 response and recovery, is to highlight state and local efforts to collect, analyze, and utilize data to inform COVID-19 crisis response and recovery efforts for racial and ethnic minority populations. Without further ado, let's get started.
Great. Thank you for having me. It's an honor to be here with you today to talk about this very important topic of inequities and COVID-19. My name, again, is Matias Valenzuela. I'm playing 2 roles here in Public Health, Seattle, King County, both the Equity Director and then Director for Community Mitigation Recovery and COVID-19 response. Just as context, King County here in the Pacific Northwest consists of about 2.2 million people. There are 39 cities, including large areas that are unincorporated. Our largest city is the city of Seattle. In terms of, I do want to provide some context in terms of this and our equity and social justice work more generally. And my history too linked to this. We have launched Equity and Social Justice as an initiative back in 2008. So we have over 12 years really doing equity and social justice work as an initiative or as a priority within King County. This started off in King County as a joint effort between public health and our executive's office. Our executive is our top elected official in the county. And since then, we have done some significant steps, such as in 2010, we passed an equity and social justice ordinance that was unanimously passed by our county council. In 2015, we created the Office of Equity and Social Justice, and I was the founder and director of that for 5 years, and then moved back to public health after 5 years, leading that office in 2020 to be the equity director here, just as soon after COVID started. So I'm going to be talking a little bit about the context of the work, because I think COVID fits in within that context. And just more generally, King County is an area that experiences very significant large inequities by race and place. This shows a map of where our people of color are, also lower income populations, where we see lower life expectancy. In South Seattle and South King County is where we see the highest proportion of Black, Indigenous, people of color, communities and populations. In the last census in 2010, we were a region that had 3 of the 30 most diverse zip codes in the nation. So we're very diverse in certain parts of the county, especially where we don't have as good health outcomes. And then there are areas that were also super majority white. You have areas that are only about 9% people of color. So at the end, what we have in just very short distances away, huge inequities. We have some of the wealthiest and also very white neighborhoods that have just very high standards of living and quality of life and life expectancy, and just a short bike ride away or bus ride away, you can have 15 years life expectancy difference. So this is a real reason why King County has been prioritizing this equity and social justice work for over 12 years now. In terms of one of the real important benchmarks in our equity and social justice work was the creation of this, our equity and social justice strategic plan, which is really the roadmap for our work in King County around this priority. This was, and also provides then the context, and it's a framework for how we do the work related to COVID-19. This plan was created by engaging over 800 of our employees, and we engaged also and spoke with over 100 community organizations. It's very thorough. It has a lot of smart measures, especially internally in terms of goal areas such as racially diversifying our workforce, in terms of budgeting. It also has a section on how we will advance equity in the region, and then has a policy agenda, criminal justice, public health, housing, a number of different areas. And I think one of the key things for us in this work, when we produce this report and this plan in 2016, and agencies are following now, is that we also very explicitly called out racial justice and racial equity as a focus of our work, just given that since the launch of our what had been an initiative, we had really failed, and as the impacts of the recession happened, that really having persistent inequities, especially for communities of color, and really needing to very explicitly call out that focus. As part of this work, we also have a theory of change, which is based on a lot of our public health principles and approach that has now been applied across all our departments. We have this unhealthy stream, which we call this how we've generally done work, not only in government, but in philanthropy, community organizations. We have focused a large majority of our energy and efforts at individual and family level outcomes, and really downstream, where we can often or putting band-aids on situations and problems, such as incarceration and poor health outcomes. And these are really driven by these poor conditions that exist, inadequate conditions. We also, in King County, we call these are determinants of equity, which are basically the social determinants of health. And these are driven by some root causes, such as structural racism and discrimination. So what our vision is actually to create a different kind of county and really create a healthy stream. In terms of and thus a healthy society and region. And really, with our equity and social justice work, we focus upstream on really the policies, practices, and values, those root causes, with racial justice at the center. And really, the idea is if we focus to create policies, on a cultural organization that really espouses all these values and incorporates it into our policies, decision makings, actions, service delivery, then we can create those conditions, the middle part of that stream, where those are optimal for everybody, and then you actually have the outcomes that you need and you're looking for. So that's our theory of change. Really, just some key concepts that we use, and we've also used this around COVID-19 as we come up with our interventions and we come up with our programs. This concept of target universalism, which we want everybody to have a particular outcome. It could be everybody wants to, we want everybody to have access to quality childcare, but we know that people have particular barriers. It might be income, it might be language, it might be geography. So we need very targeted and focused strategies to overcome the barriers so we get people to those outcomes that we want. One of our programs, Best Starts for Kids, really uses this as a framework to guide its work. We also are trying to dismantle systems. There's plenty of systems that aren't working. The work that we've done around human resources, for example, is an example of this, where we have gotten rid of some of the traditional requirements in terms of educational requirements, and really focusing on the competencies. What are the competencies that we need people to have in order to do the work? Then focusing on people and places where the needs are greatest, and really investing in those areas. And then process equity. So how can we actually involve community and even also our employees early and throughout the process to be able to get different outcomes? A couple just examples before I focus now more exclusively on COVID, is Communities Opportunity, which is a program that we have that really very explicitly focuses on those areas of the county with greatest needs and with very focused investments there and through a community-driven process. I already talked about Best Starts for Kids very briefly, which focuses on prenatal care. This is focuses from prenatal to youth adult programs. It's levy funded, and it really puts our theory of change into action. With zero youth detention, we've actually moved youth detention to have a public health approach, and we've been able to through the years, and actually decades now, a couple decades, we've been able to really reduce from any given night from having over 200 youth in our jails to now having anywhere from 20 to 30 on any given night. And really, earlier this year, our executive made a commitment to repurpose the last of our youth jail by the end of 2020 and not have youth detained in jails anymore. Or with a mobility framework, which really the driver for that is need and speed. So really using equity as a major focus in terms of whether we're increasing services or decreasing services, really focusing on those communities where we have the greatest needs. Moving into COVID, one of the things that we did very early on was develop a data tool, a vulnerability index. And this we knew from the very beginning where the needs existed, and this was critical in driving our programs, our approaches, where we needed to put our efforts. Here you can see their indicators for older adults, high-risk individuals and communities, race and ethnicity, poverty, and language. Just as an example around language, we have huge diversity. We regularly are translating now for COVID-19. This is more than we've ever done before, into about more than 30 languages on a regular basis. And then in addition to that, it's around connecting to the communities. It's around really that they have not only the translate information, but to be able to use it in a way that's powerful. This I'll be talking later about our community mitigation recovery work and our task forces and the different ways that we reach community. In terms of the disparities that we see in King County, it's very much similar to the story that we're seeing in the rest of the country. Our most impacted communities are Native Hawaiian Pacific Islanders. They have rates of about 7 times greater than whites. Hispanics and Latinx communities is from 5 to 6 times greater. Among Black and African American, it's about 3 to 4 times greater. American Indian, Alaska Native, it's anywhere from 2 to 3 times greater. And then we see the geographic layout in terms of where we see the cases in our county, which very much reflect the map that I was showing before, that where you have more, especially in South Seattle and in South King County, is we're seeing the most cases. In terms of also, if we see across time, and the shift that's happened there is early on, we were a national hotspot here and having some of the first cases, very much focused on the white population and older population, a lot of long-term care facilities. Now, as you can see, increasing number among people of color, especially the Hispanic Latinx population, which is many times over what they represent in terms of the portion of the population. They make a significant number of the cases that we see. Some of the causes of this, and there are a number, and I'm just highlighting some of the ones, and I think in the national literature and debates, a lot of these have gotten attention as well. One, of course, is healthcare access. There are higher rates of uninsured and underinsured among people of color. Also, if you saw the high numbers in terms of the Latinx population, and especially some communities like undocumented communities, there's the added challenge of not qualifying for federal health programs. In our state, we do have some services that are covered for COVID, but generally that is something that many undocumented workers and communities, populations don't have a healthcare home and don't have a regular healthcare provider. Of course, there are issues around the distrust of the healthcare system. We're seeing this, have seen this in our region, especially with the Black community, and we're seeing this also in previewing this now as we think about vaccination, where there is hesitancy and distrust, especially that we're hearing from our Black community partners. Similarly with the Latinx population, there's a tendency to delay care. Also, we know underlying health conditions are key, so more likely to have complications due to underlying health conditions that we know are driven by these determinants of equity, social determinants of health, so really having those access to healthy neighborhoods, foods, jobs, those are the big drivers. And around this too is those final items around living and working conditions and really the high number of essential workers. So many of our communities of color and those families, they live in multi-generational households. So people and they're also essential workers, so having to go out to work, coming back to their households and putting others at risk. Especially if we think about the undocumented population, also they're having to do a very hard choice here between having to choose between being exposed and putting food on the table, especially if they don't qualify for federal programs and benefits. And one of the key area that I have been directing, and really as we use the data and the information that I've been presenting before to really respond to community, is through this major part of our response for COVID-19. It's the area that I direct, it's community mitigation and recovery. The goal here is to help limit and prevent exposure to coronavirus. It's to lessen the negative social and economic consequences. So really, we're trying to address things such as housing and food security, many of the things, support for small businesses, and really centered on the principles of equity. So really prioritizing racial and ethnic and cultural, linguistic, and economic groups that are highest risk. And that is very explicitly for each task force, that's what they need to be doing, and then lifting up community guided and developed solutions for this work. I think the quantitative data is extremely important to drive how we do it, how we where we want to prioritize testing, for example. But I also look at, as we talk about this, the community voice. That qualitative data is key in being able to respond effectively. We have, through the task forces, those are made up from people from the county, and also with representatives from community are part of that. We also have a pandemic community advisory group, which is key. We have 40 organizations and sectors that inform us in the decision making. So there have been a number of key issues. For example, when we were creating a initial face covering ordinance or order, it ended up being a directive in King County because we heard concerns from the Black community around being profiled and the risks to them in terms of wearing a mask, and them not necessarily feeling safe in terms of the reactions that they would get, or people with disabilities, the challenges of them if they're not able to, if they're with a family member, for example, and they can't communicate because they don't have one or are having to wear a face covering. So the key in informing public health and our executive's office around policies, and also just general operational issues. One of the other groups, there's a lot to be able to highlight here, because this is kind of the heart of our community response and how we're working with community, is I'll just call out the community navigators. We have leaders from communities who we have now on contract that they're sharing information and informing us when things are not working, and also help us get the information out. There's been great examples when for example, we have isolation and quarantine facilities. We heard from these community navigators through their networks that people were not getting information about these facilities. We've also heard that sometimes healthcare providers have not been providing adequate information to individuals who have tested positive for COVID. So these are really our ears to community to be able to hear and adjust effectively to what we're hearing from them. Some of the things, just say as last point, just kind of things that are essential, I think, as we do this, is and how can we really focus on equity in times of crisis? I mean, it's working at all levels. Our commitment from leadership is key. We actually have, as part of our COVID response, we have an equity response team, and they're part of our incident command, and having them there at the table as decisions are being made is critical. Just linking work to major policies, practices, strategic planning. So as we are making major decisions now, as we are doing, coming up with our testing plans and where we test, is really using the data, using our equity perspective and hearing from community in terms of how we do that. Really leading from work from values and using both the empirical data and the qualitative data, which I was referring to, those community voices, creating and applying available tools and frameworks, such as we have an equity impact review tool. So actually not just having that written on paper and sitting in some bookshelf, but actually something that gets used as part of the response and setting that expectation. And really concrete, clear actions that we need to take as government, but are defined by those who've been most negatively affected. I will really end by talking about just the latest work that we have been doing, that we declared in June, both our public health director and the King County executive, racism as a public health crisis. And as part of this, and working now with community and creating a policy agenda that is with community and responding to community demands, especially from Black and Brown organizations, we are committing to really having the same vigor, resources, and energy to addressing racism as we have with COVID-19. Just, I had mentioned the Pandemic Community Advisory Group. That group voted and pushed forward an effort to now rename itself to become the Pandemic and Racism Community Advisory Group. And also this month, our executive is going to be announcing the new biennial budget that really pushes us away from investments in the criminal legal system and more to align with our principles of equity and social justice. Here you can just see some of the resources in terms of our tools, our equity impact review tools, community engagement guide, strategic plan, some of the data resources that I have been referring, plus a dashboard in which we have different dashboards, but including a race and ethnicity dashboard. With that, I would like to pass it on to my colleague and the next speaker.
Thank you. I'm Vivian Lashley-Bibbs. I'm Director and Epidemiologist for the Office of Health Equity at the Kentucky Department for Public Health, and I'm also President of the National Association of State Offices of Minority Health. I'd like to thank the Office of Minority Health for putting on this symposium and allowing me the opportunity to present today. I want to talk today about a tool that we're using in Kentucky, which is the Social Availability Index tool, as we work with the Environmental Public Health Branch in our state to look at how we can address some health inequities that are happening in our marginalized and vulnerable communities and our minority communities in Kentucky. And the Social Vulnerability Index tool, it's really a tool that was used for disaster preparedness, but we're looking at how we can look at using this tool and determining the resilience of communities when they're confronted by stressors such as COVID-19, natural disasters, et cetera. And just to tell you a little bit about the index itself, it uses census data to determine the social vulnerability of every census tract. The SVI ranks each tract on 15 social factors, and they're grouped into 4 categories: socioeconomic factors, household composition and disability measures, minority status and language measures, and housing and transportation measures. And if you go to the Kentucky Environmental Public Health Tracking Network, when you click on the Data Portal tab, it will take you to the Social Vulnerability Index, which I'm highlighting here. So what are the benefits of using the SVI in addressing health inequities? So I'm sure most of you all know by now that have been doing health equity work and addressing social injustices and inequities in communities. We know that place matters when it really comes to health. And we really need to identify the impact of social determinants of health on a statewide health landscape. We need to identify the SVI indicators that have the greatest influence on local community health. We need to identify down to the census tract level communities of greatest need. We need to learn from those communities with the greatest health need and those that are even in good health despite an adverse SVI indicators. What makes that community different from the community next to it? And then to build collaboration across sectors to promote health equity. So when we look at the Social Vulnerability Index, and we see a map here, we're looking at the tabs across the top where you can see all of the 4 buckets that I was referring to, and what that looks like for the state of Kentucky as it ranks from 0 to 1, with 0 being the least vulnerable to 1 being the most vulnerable. So how can we get down to the census tract level and really talk about what's happening in our communities? So a census tract gives us a small, relatively permanent statistical subdivision of a county, uniquely numbered in each county with a numeric code. And that minimum population anywhere from 1,200 inhabitants to a maximum of 8,000. And why is that more important than using a zip code? Well, zip codes were originally for postal, right? And they can sometimes have multiple zip codes within a particular county, as to where SVI and census tract data is more consistent. It doesn't necessarily cross county lines where zip codes potentially can. So when we talk about the Social Vulnerability Index, we can see the 4 areas: the socioeconomic, the household composition and disability, minority status and language, and housing and transportation. And what really comprises those 4 buckets? Well, if you look at socioeconomic, these are the indicators that are comprising that bucket: poverty, unemployment, income, and education, For household composition and disability, it's the elderly, children, those that are disabled and single parents. A minority status and language being a minority itself, and then with limited English proficiency or speakers. And then housing and transportation, large apartment dwellings, mobile homes, overcrowding, no vehicle at all, and then group quarters. So that helps us build our map. So when we're looking at these different buckets, we can determine what's going on in those communities at the census tract level as it relates to those social indicators. So we're using the SVI tool, but we're also trying to understand disease convergence within the context of a health opportunity. So GIS technologies become a valuable tool to help us look at what's happening with social determinants and how that's impacting health and widening those disparity gaps that we see among our Black and Brown communities. How do we understand where those disparate health outcomes are greatest? And how do we really get down to the census tract level to see where they can occur and where they can be additive, where there's multiple comorbidities and where there's multiple social indicators at play, those drivers at play. And we've come up with what's called a disparate health convergence through GIS. That's the term we've coined to describe this technique. It allows us to think about health disparities and health inequities and how they're distributed across geography. It helps us determine which social determinants of health are correlated with that convergence analysis of disparate health outcomes. So place really does matter. And I'm hoping in the following slides, you'll get a good example of how we're using this tool to really drive some of the decisions that we're making in the state of Kentucky as it relates to not only chronic disease and addressing some social determinants of health, but how it's going to help us look at COVID-19 as far as testing and contact tracing, and also in recognizing the communities at greatest risk for vaccine uptake. So looking at the following, we've used the analysis of Lexington Fayette, and we've looked at some of the chronic diseases that are prevalent in these communities. And so we're looking at two distinct areas. And we see that diabetes, poor mental health, stroke, asthma, coronary heart disease, high cholesterol, and high blood pressure are very, very prevalent in these communities. We have a lot of folks at greatest risk, as you can see in the slide, that are in the darker colored areas that have the greatest morbidity and mortality from these diseases. So as we look further and we use the SVI tool, we can really pinpoint where those areas are with those high comorbidities, where the SVI is the greatest, meaning where those folks, where those high-risk census tracts are with the greatest high-risk folks that have those multiple comorbidities. So the larger the yellow bubble, the larger the yellow dot, the greater that the vulnerability in that community within that census tract. That becomes very important when you're trying to determine where resources go, especially when they're limited, and where the greatest need is for that community. So let's look at another area as within that census tract, within Lexington, Kentucky. We can use BRFIS data along with the morbidities that you see below were based on BRFIS data. And then you can overlay the SVI to see again where those communities are with the largest yellow dot. Those are the communities that have the greatest SVI. Those are the communities that have persons at greatest risk. Those are the communities where we need to focus and apply programming and much needed resources. So when we get down to the census tract level, what does that tell us about these communities? How vulnerable are these communities? What's the demographic makeup of these communities? And on the slide here, you can see age, race, gender, poverty, those other determinants that we think of that really impact long-term health and even short-term health. So we really want to get down to see how we're doing as it relates to using this tool and determining what needs to happen at the county level, at the community level. So the following slides are going to depict disparities based on the demographic characteristics of census tracts within that convergent disparate health outcome analysis. So we're looking at these communities within this certain census tract, and we're looking at the vulnerable populations and the composition of those communities by race, ethnicity, socioeconomic status, education level, and we're seeing where, when we overlay these and do the convergence analysis, where we need to focus. And I've just highlighted a few on the slide. I'm hoping that you can see the racial breakdown, the economic breakdown, those that are in poverty, those that are over a certain age, and those with education level. So what are the essential data elements we need to advance health equity? And how, moving forward, can we use this tool along with the CVI tool, which has been developed to look at specifically COVID data and how it's impacting vulnerable communities, in which we plan on moving forward using that tool as well. But we're also looking at where the disparity gaps were in our COVID rapid response and recovery, and where we need to overlaying that data with the SBI tool, where we can have the greatest impact moving forward in the recovery and response to COVID-19. So what does it tell us? This tool, along with others, helps us to understand where disparate health conditions occur simultaneously and where they're occurring at the worst levels. We need data to reflect how these health disparities and health inequities and social determinants are distributed by geography. We can have census tracts right next to each other with one community thriving even though they have a high SBI and another community with a high SBI that's not doing well at all. What are some of those underlying root causes? What are some of those systems and structural or institutional barriers or policies or processes that are driving that SBI or driving that community to have the picture that it does when it presents as having a SBI of 1, of being the most vulnerable? How can we best address the unmet needs of those communities? These tools are imperative if we really want to start thinking about closing the disparity gap and really looking at down at the census tract level within communities to see what is helping them either not thrive or thrive, and what we can do to either improve that or help them continue to thrive. I want to go back to one slide for just a second and think about how these health disparities and health inequities and social determinants, that their distribution by geography, from a health equity standpoint, how does that help us? And how does it help us understand which social determinants are correlated with the convergence of disparate health issues? The SBI and additional data analysis will help us satisfy those conditions. And as we move forward, I would encourage you to use tools like this to take a deeper dive into what's going on into communities at the census tract level, to not just really focus on maybe the downstream factors that are impacting health, which are those things that we traditionally do, looking at diet, nutrition, physical activity, disease presentation, but really move past even the midstream factors of social determinants of health. We know that transportation and access and the physical and built environment are all critical and impact long-term health outcomes. But maybe looking at tools like this one and looking at census tract level data and really taking a deeper dive can help us maybe focus on some of these communities that have housing issues, that are overcrowded, that have lack access to schools and healthcare, et cetera, and think about why is that? What are some of those root causes? What are some of those policies or structural or institutional things that have over time perpetuated things that we're seeing in communities. And maybe using tools like this will help us have that conversation. It'll give us an additional piece of information to leverage when we go in and talk to those that make decisions and those within the communities, to not only help them better understand what's happening within their communities, but to also help those that can make decisions and influence where resources and allocation of funding, et cetera, goes, to be better focused and in tune to the communities with greatest need. So I want to leave you with a few parting thoughts, that we're not the only Department for Public Health that's moving just beyond health disparity data. There are other states that are also looking at data tools like the SBI and Health 360 and some other tools, Community Commons, et cetera, to kind of really look at what can be done at the community level. How can we take that lens and magnify what's going on in communities down to the census tract level? Using tools like the SBI and the COVID-19 Community Vulnerability Index, or CVI, as data tools to better address inequities will help us do that as it relates to our most vulnerable populations. We need to move beyond our silos, that being programmatic silos, professional and academic silos, and collaborate to share expertise in solving complex health equity issues. We can't do this by ourselves. It's going to take a collaborative approach. We need to really think about how we can look at each other for some of those answers. We've got to overcome the mindset that health equity is out, that it's internal to public health, that it really is outside of public health practice. So I really want us to think about how we can do that, and then once we do that, how we can share that information between states, with other colleagues, so that we can address this as a nation, and that when we see those rankings where we rank with other countries, Kentucky can move up and be showing that we're truly making progress and caring about all of our citizens and not just a few. So I thank you for giving me this opportunity. Please reach out. My email is there if you have questions about any of the information that I've shared today. If you'd like to talk further about the SBI tool or the CVI tool and how we're using that in Kentucky and an additional analysis that we're doing as it relates to the COVID-19 response, please reach out. I'd be happy to share. Once again, I thank you.